Thank you everyone for joining us today. My name is McKenna and I am from the Academy for Continued Healthcare Learning, one of the groups putting on this presentation, which is titled Modeling Center of Excellence Practices to Improve Care of Patients with Biomarker-Driven Thyroid Cancer. Today's session is supported by an educational grant from Lilly and is provided by the University of Chicago Pritzker School of Medicine and the Academy for Continued Healthcare Learning. This is geared towards the medical team that takes care of patients with thyroid cancer. And we have a couple of learning objectives here on the screen that we hope you guys can walk away with a little bit of a better understanding. This is an accredited session. So the University of Chicago Pritzker School of Medicine is ACCME accredited and is offering up to 1 AMA PRA Category 1 credits. And we'll provide information at the end of how you can get that credit if you are looking for it. Just so you know, PAs, NPs, and nurses can earn a certificate of completion and then get credit through their groups through reciprocity agreements. At the end, we'll provide you with a certificate code and you can go to our website, achlcme.org, and there's a button in the upper right-hand corner that says use certificate code. You'll put that in there and it will take you directly to the post-test and evaluation. And we ask, even if you don't need credit, if you could still complete the post-test and evaluation and let us know if there's anything that was super helpful or unhelpful so we can make changes as we develop future education. So this is a list of our chairs who provided the content and worked with our scientific team on developing this program, and just some information about them. And today's presenting faculty, Dr. Lori Wirth. This is her financial disclosures. And just so you know, Dr. Wirth is the medical director of the Center for Head and Neck Cancers at the Massachusetts General Hospital Cancer Center and is an associate professor of medicine at Harvard Medical School. And we are so thankful to have her working with us on this program. And then this is the financial disclosures for all of our chairs who, again, just helped us with this content and developing this program. University of Chicago staff members and ACHL staff members who were involved in this program have no relevant financial disclosures. And this just goes over our disclaimer and off-label discussion advisory. We did create this in accordance with ACCME standards. And there is some treatment of medications that are not approved for the treatment of advanced or metastatic medullary thyroid cancer. And with that, Dr. Wirth, I'm going to hand it over to you.
Great, McKenna. Thank you so much. All right. So I'm going to be talking about optimizing testing for RET alterations, particularly specific to thyroid cancer. The presentation is geared a little bit more towards providers than to patients and family. However, I will be talking about the slides mostly for the patient and family members' perspective as much as I can. So we'll be talking about our understanding of the role of RET alterations related to cancer, what the mechanisms of carcinogenesis are, what cancers do we see RET alterations in, and we're also going to be talking about RET testing. So basically there are two types of RET alterations that we see in oncology shown here. On the top cartoon, we see a depiction of what happens with RET gene fusions or RET gene alterations. Basically, what you can see here in the top part of the cartoon is what the normal RET gene looks like. What can happen when cells are multiplying and dividing is that the RET gene can break apart, the chromosome there can break apart and then can be fused with a different chromosome. In this example, it's fused with the KIF5B gene, so that in the middle you get the RET gene fusion. This example is a KIF5B RET gene fusion. And we see these RET gene fusions in about 10 to 20% of papillary thyroid cancers, maybe 15% of poorly differentiated thyroid cancers. And we also see RET gene fusions in some patients with non-small cell lung cancer. Here on the right, you can see when the gene fusion is translated into a protein, the abnormal protein product basically meets up and forms a dimerization within the cell, and that causes activation of the kinase, which is the business end of the protein, and that causes signaling to the nucleus of the cell for that cell to multiply and divide, multiply and divide, multiply and divide. That's how these RET fusions can cause cancer. The other type of RET alteration, however, that we see in thyroid cancer are RET point mutations. We see those types of gene mutations in medullary thyroid cancer, and that's shown here on the bottom. So here we see the RET gene, and here is an example of a mutation, a point mutation at RET C634. So we see RET mutations in everyone who has the inherited version of medullary thyroid cancer, as well as in almost 60% of patients who have sporadic medullary thyroid cancer that's not inherited from the mother or the father, but those RET mutations, rather than being inherited in all of the DNA, arise within the thyroid gland itself. And then those mutations cause activation of that business end of the RET kinase within the cell, again, causing a signal to the cell nucleus to grow and multiply and divide, grow and multiply and divide. That's how we get medullary thyroid cancer arising out of a RET mutation. So there are multi-kinase inhibitors that do have some anti-RET activity that have been studied and approved in thyroid cancer. These multi-kinase inhibitors, or MKIs, do have some activity in patients, though it's relatively modest. And one of the problems with these multi-kinase inhibitors in RET-driven thyroid cancers is that they do target RET, but they target other kinases as well. So they lack the specificity just for RET, and that leads to increased side effects related to the multiple kinases that these drugs target. That leads to difficulty in ratcheting up the dose so that you can get really potent RET inhibition. So we think that while these multi-kinase inhibitors do have some anti-RET activity, because of the inhibition from the other kinases and the side effects that relate or that are a consequence of the inhibition of those other kinases, we can't get really strong RET inhibition with the multi-kinase inhibitors. We now, however, have 2 RET-specific inhibitors in our arsenal to treat RET-driven cancers, namely pralsetinib and selpercatinib. Both of these 2 drugs were designed to really potently and specifically inhibit only the RET kinase so that we can have really strong RET inhibition without the inhibition of the other kinases that are responsible for causing a lot of the side effects in the multi-kinase inhibitors. By the way, I wanted to say to the group, those online and those also in the room, I'm going to go through some questions and just kind of talk through them, but we have a Q&A at the end. And I thought given the format, it's probably best if we save all of the questions and comments until the Q&A in the end. If you want, though, for those of you who can, put them in the chat now or as you think about them, and we'll try to be sure to answer everybody's questions and comments at the end. One of the things I want to talk through in this program are the challenges for establishing a good workflow to assure that we have good testing for RET alterations for everyone with thyroid cancer who is going to possibly need RET-directed therapy in the future. And one of the challenges is simple, just getting enough tissue for the testing. And so how can we improve upon that part of the process? Getting enough tissue seems really simple, but simple things are often complicated in medicine and in the clinic. And this graph kind of represents how complicated something really simple can be. So you've got a patient with the tumor, the oncologist or another doctor, generally the person who's ordering the biopsy, but they're not the person doing the biopsy. Doing the biopsy might be an interventional radiologist or a surgeon. And so the oncologist has to communicate to the person doing the biopsy that we needed a biopsy maybe to make a diagnosis, but we also need a biopsy that will give us sufficient tissue for molecular diagnostics so that we can look for red alterations and other alterations that we can see in thyroid cancer as well. And then when the person does the biopsy, you want to make sure that we want that person to make sure that there's enough tissue at the time that they do the biopsy. We don't want to send the patient home and then find out 3 days later that there's not enough tissue in the biopsy to do all of the testing that we want to do. So you want to ideally have a rapid on-site evaluation of the adequacy of the tissue specimen to make sure that you've got a good enough biopsy to get all of your answers. And if you don't have enough tissue, then right then and there, you would want the person doing the biopsy to work with the patient to probably do another pass, another biopsy to make sure that we have enough tissue to make a diagnosis and to do that all important molecular diagnostics. But not only do you have to have enough tissue, you also have to have the right test for the tissue at hand. So let's talk about that. And so just again, in terms of this workflow, it really is complicated. Molecular testing really does need multidisciplinary collaboration. And this kind of collaboration amongst multiple team members is just really challenging to do in this day and age. Now, often fine needle aspirations do provide enough tissue for not only making a diagnosis, but doing the molecular diagnostics as well. Sometimes we can also do core needle biopsies that are a lot like fine needle aspirations, but it just uses a slightly bigger needle and you can get a slightly larger piece of tissue. Core needle biopsies might give you a slightly better chance of getting enough material for both the diagnosis and the molecular diagnostics for things like RET testing. But in many places, those two are interchangeable. And then we talked about the on-site evaluation to make sure that you get enough tissue from the biopsy to do all of the testing that you want to do. And the lesion selection is important as well in choosing which lesion should be biopsied. And I'm talking about this to give you an idea of just how complicated the decision-making process is. So say a person, for example, has a thyroid nodule and then lymph nodes in the neck. If the thyroid nodule is the biggest chunk there, you might think that that might be the best place to biopsy. But if the lymph nodes in the neck look really suspicious on an ultrasound, for example, for harboring cancer, that actually might be a better place to do a biopsy, because if you see thyroid cancer spread to the lymph nodes, not only do you have the diagnosis, but you also have some staging information, and you also have some information about what kind of surgery is going to need to take place. You can't just address the thyroid primary, but you have to have the surgeon address the lymph nodes as well. So sometimes going after a suspicious looking lymph node is going to answer 2 questions, whereas going after the primary might just answer 1 question. Or you might want to do both sites of disease in order to have as much information as possible. I think one of the important points is that when we're thinking about maximizing molecular diagnostic testing or biomarker testing, it really requires us to shift from thinking about the biopsy as a tool to make the diagnosis to the biopsy as a tool for complete pathologic staging, pathologic diagnosis, as well as molecular profiling, and we can put all of that together really for informing patient-specific treatment decisions. So how should tissue be obtained from bone lesions? There are some types of thyroid cancer that can metastasize to the bone. Follicular thyroid cancer, for example, is more likely to metastasize to the bone, or sometimes medullary thyroid cancer. And so the way that bone biopsies get processed, they usually are put in a decalcification medium to get rid of the calcium before the rest of the pathology processing of a bone biopsy, so that the pathology department can easily slice up the specimen and do the staining and so forth that they need. But that decalcification of the bone biopsies will destroy the DNA in the tissue. So you can't do molecular diagnostic testing from a bone biopsy if it's been put into a decalcification medium. So you really have to be thinking in advance before ordering the biopsy, before having the biopsy, to make sure, if I do a bone biopsy, am I going to want molecular diagnostics? And if so, how does that need to be processed? If you don't know the answer off the top of your head, you can call your pathologist and discuss it with them. And I've done this before, and so I know that there are different media that the interventional radiologist can place the specimen in instead of decalcification medium, so that the DNA doesn't get destroyed, so that then we can do molecular diagnostics. But if I forget to discuss this and make sure that that's very clear as I'm ordering the test, then I might lose out an opportunity to do that really important molecular diagnostic. So again, I'm just a great example of how something really simple can be pretty complicated. And the more we plan in advance, the better. Now, there's a lot of discussion in the oncology world about liquid biopsies. And liquid biopsies really are a major step forward in terms of diagnostics in the cancer world in the last 10 years. Basically, these tests are a simple blood test where a patient has a blood draw, and then you can extract DNA from the blood, analyze the DNA from the blood, and look for circulating tumor DNA in the blood, and sometimes find out a lot about a cancer from those blood tests. So circulating cell-free DNA or ctDNA, circulating tumor DNA, or liquid biopsies pretty much are all talking about the same kind of blood biomarker testing in cancer. So there are great advantages. It's just a simple blood test. You can get the results pretty quickly as well. The problem in thyroid cancer is twofold. This kind of testing works best with cancers that have a lot of turnover of the cancer cells. So those cancer cells are multiplying and dividing very rapidly. Then you get spillage of the DNA into the bloodstream. That's easy to measure. And a good example of that is somebody with metastatic non-small cell lung cancer, for example. Many thyroid cancers, however, don't grow quite as fast as that. And so the shedding of the tumor cells into the blood is less. And so these liquid biopsy tests often aren't sensitive enough in thyroid cancer to be very helpful. In general, liquid biopsies are not good options for us in trying to figure out a lot about a patient's thyroid cancer. The other one problem with liquid biopsies is that they're not very sensitive for fusions. It's hard for liquid biopsies to detect those fusions that we talked about, like RET fusions, for example, because those are harder to find in a liquid biopsy. And those are really relevant for many patients with thyroid cancer. So these tests are being refined and redeveloped as we speak. So, you know, in the near future, I think we're going to have more sensitive next generation liquid biopsy tests that are going to be better specifically for our thyroid cancer patients. So, I think we have to think about what are the barriers between greater collaboration amongst all of our doctors in this complex world of cancer diagnosis and molecular testing, molecular diagnosis as well. And we want to be as thoughtful as possible regarding the steps that can be taken to improve the collaboration. And I think that one of the really important steps are patients who are well informed and who ask good questions. And that's one of the reasons why we're doing the program here today, so that people can be empowered to not necessarily have all of this information memorized, but to know what kinds of really good questions can be asked when they're seeing their doctor. And always a good strategy is write your questions down before you're in the doctor's office or while you're waiting for the doctor to arrive, and make sure that you've got your questions pulled out and that you've had a chance to ask all of your questions before you wrap up the visit. So anyway, tracking tissue samples is another thing that seems really simple. From the time that the test is ordered till you get the report of the test. How do you optimize the workflow so that that simple process really can unfold in a way that's seamless, and that you always get the results and they're always available. Again, something simple that actually is really quite complicated. Communication is the most important thing here. Communication between the doctors, the people doing the biopsies, triaging the tissue, having a champion from start to finish can really help a lot. Often it's the doctor. Some big institutions will have nurse navigators. Some institutions have genomics navigators as well, who can really help smooth out this process as well. But one of the things that I wanted to mention, and this is where patients can play a really important role, is in the results. So most big institutions these days, and many smaller institutions and small doctors' offices, will have electronic medical records where so much information is available at your fingertips and on your computer, and pushed to the patient through the patient gateway or whatever patient portal your institution has. But one of the things that's very complex that we don't have a very good electronic system for yet is when tests are sent out to other places and then the results get sent back to the doctors. And at many places, that's exactly how molecular diagnostics get processed. So many places will do a biopsy on a cancer, send it to a commercial company. One example is Foundation One, which is in the Massachusetts, Cambridge, Boston area. And then the Foundation does the molecular diagnostics. Then they send the results back to the ordering physician through a portal that the physician can log on to. Then the physician can get those results. They can be shared with the patient through that portal, but that doesn't always happen. Those results, however, don't automatically go into the electronic medical record at your doctor's institution, unless the doctor takes an extra step on his or her own part to get those results uploaded into the electronic medical record. And then when outside results are uploaded into the electronic medical record like that, they're actually really hard to find in the future, to search for in the future. And it's easy for those molecular diagnostic results to kind of get lost in the shuffle of the complicated life of a cancer, complicated life of a cancer patient, the complicated life of a cancer doctor's office. So one of the key people that can help make sure that those results are always available are patients and their family members and their caregivers. And the more that people can hang on to those key pieces of result information, the results of their biopsies, the results of their imaging, the results particularly of their molecular diagnostic testing, then the results are available whenever somebody is wondering exactly what the result of that one test was, particularly if it was a couple of years ago. All right, so I'm going to talk about a case. This is a case of a patient with medullary thyroid cancer. This was actually a patient of mine. He was diagnosed with a sporadic, not inherited medullary thyroid cancer in 2014 when he was 47 years old. MTCs make calcitonin and CEA as tumor markers, and before surgery, his tumor marker levels were very high. He had a total thyroidectomy, and the pathology showed a 2.2 centimeter primary medullary thyroid cancer with extrathyroidal extension, meaning that the thyroid cancer was spreading outside of the thyroid gland itself. There were satellite tumors within the thyroid gland, and 11 lymph nodes were removed. They all had medullary thyroid cancer in them, and one of them was fairly large, 2.5 centimeters. He underwent another surgery in December of 2014, and three more lymph nodes were removed. One was very large, 4.2 centimeters, and another 3 lymph nodes were negative. One of the challenges when we're talking about molecular testing in medullary thyroid cancer, to make matters even more complicated, is that there are two types of RET alterations related to medullary thyroid cancer, and very different molecular diagnostic strategies for looking for those two different types of gene mutations. We see about 25% of medullary thyroid cancers caused by an inherited germline RET mutation that the person inherited from their mother or their father and can pass on to their kids. Whereas 75% of medullary thyroid cancers don't have those germline or hereditary RET mutations. We want to make sure that everybody who's diagnosed with medullary thyroid cancer gets tested for the hereditary RET mutations, because it has implications not only for that patient, but also the patient's first-degree family members. As I said, all patients with newly diagnosed medullary thyroid cancer should ideally have genetic counseling and be tested for germline or hereditary RET mutations. And that's regardless of what stage of disease they have, whether they have just a small primary tumor or metastatic disease. Also, regardless of whether they have a personal history of other endocrine cancers that you can see in the hereditary version of medullary thyroid cancer, and also regardless of whether or not they have a family history. And that testing is basically germline testing, and it's done off of the patient's blood. That gets sent to the Mayo Clinic or other places that do this germline testing. And if there is a germline test confirmed, then you know that that RET mutation is in the patient's medullary thyroid cancer. But you also know that it's possible that that germline mutation could be shared with other family members of that patient. And you have to do genetics counseling for those people and offer them testing so that we don't miss this really important diagnosis. So say a patient like mine has had germline RET testing, and it turns out to be negative. And that's in the scenario over here. So there we know he's germline negative. And so then we think about tiered NGS testing. And so this is, oh, I'm sorry, I'm getting ahead of myself. I don't want to go into tiered NGS testing for germline RET yet, because it's just a little bit too complicated. Again, when we think about barriers to carry out germline RET testing, what are some of those barriers in the clinic? So there are multiple different germline RET mutations that we can see in medullary thyroid cancer. If we have a test like these first two tests here, Sanger sequencing or qPCR testing, we can look for some of the known inherited RET mutations, but not all of the known inherited RET mutations. Whereas if we use next generation sequencing, it's a much broader panel of testing that is much more sensitive to pick up all of the potential inherited mutations that can be found in a patient. So these days, primarily the molecular testing that we're doing here in the United States is with NGS or next generation sequencing. So my patient did have germline RET testing, and his was wild type, which means that he didn't have an inherited RET mutation. So 2 years later, his tumor markers were going up, and PET CT showed he had a lot of bulky disease in the neck, in the center of his chest. So we started him on a multi-kinase inhibitor at the time that was FDA approved for medullary thyroid cancer called cabozantinib. He did well on the cabozantinib, had a beautiful response in terms of his tumor markers dropping nicely. And we saw on CT scans, there was a decrease in the bulky thyroid bed disease, as well as in the neck adenopathy and mediastinal adenopathy in the center of the chest. So he had a really nice response to cabozantinib. However, in October of 2018, he stopped cabozantinib because he lost his insurance, and he was actually lost to follow-up. So we didn't see him for several months until in February of 2019, he came back to clinic, and the reason why was because he developed a very large right neck mass. And so at that time, his tumor markers, the calcitonin and CEA, had both gone up significantly. And he had a CT scan that showed significant disease progression. So at this point in 2019, we now had in clinical trials the RET-specific drugs that were being tested. So we wanted to see, we knew that he didn't have an inherited version of a RET mutation, but could this patient with medullary thyroid cancer have the non-inherited sporadic version of a RET mutation? So the ways to do that are, again, with single gene testing, or preferably with next generation sequencing of the tumor, not the blood, for a somatic RET mutation, not a germline RET mutation, that arose in the cancer. And so you can do that by biopsying the cancer and sending it off for next generation sequencing. And if you find a RET mutation that occurs in about 60% of the non-familial medullary thyroid cancers, then you might have a new treatment option available. So we did that with this patient, and we did indeed find by tumor NGS testing a RET deletion, which is very similar to a mutation in his cancer. And so he became eligible for enrollment in the trial Libretto 001 that was studying selpercatinib at the time. So what reasons underlie the initiation of systemic therapy prior to receiving molecular testing in patients? And I think this question is in this discussion because in this day and age, we have so many different potentially druggable gene alterations across the whole array of thyroid cancers that for most patients who need systemic therapy, we really want to make sure that we're doing this molecular testing first prior to initiating the systemic therapy so that we get each and every patient on the right drug. So if there's a RET mutation in somebody who's got progressive medullary thyroid cancer, we now have a drug like selpercatinib that is FDA approved. And so we want to know that the gene makeup of a medullary thyroid cancer prior to initiating therapy so that we can get the right patient on the right drug. One potential exception to that rule is in somebody who might have anaplastic thyroid cancer that's very rapidly progressive, because this kind of testing can take a little while. The turnaround times these days are really fast, but sometimes people with anaplastic thyroid cancer need to start therapy right away. So that's one exception to the rule. So when patients have medullary thyroid cancer, if they have unresectable, local regionally advanced disease in the neck, persistent disease in the neck, with or without metastatic disease, or metastatic disease, we want to identify every patient in those categories of disease states who has a RET mutation, so that we can think about offering them RET-specific therapy rather than the multi-kinase inhibitor therapy. As I mentioned, selpercatinib is FDA approved for these patients as young as the pediatric patients who are 2 years of age and older. Now, pralsetinib is the other RET-specific drug that was studied in medullary thyroid cancer in the ARROW trial, but the confirmatory phase 3 trial that the FDA requires for full approval following accelerated approval was not done with pralsetinib. So pralsetinib voluntarily withdrew the approval in medullary thyroid cancer because they did not go ahead and do the required phase 3 trial. The selpercatinib phase 3 trial did, however, get completed, and therefore selpercatinib did receive a full approval by the FDA. And that trial was Libretto 531. So this really busy slide here shows the data for Libretto 531. This was an open label, international randomized phase 3 trial that enrolled patients with RET mutated medullary thyroid cancer that was progressing, and randomized patients in a 2-to-1 ratio to selpercatinib or physician's choice, cabozantinib or vandetanib, the 2 multi-kinase inhibitors that were FDA approved a number of years ago. And there was a 2-to-1 randomization. So out of every 3 patients, 2 blindly got or randomly got randomized to selpercatinib, and 1 got randomized to cabozantinib or vandetanib. And the primary endpoint of this trial is called PFS, or progression-free survival. And basically what progression-free survival means is that the patient is still alive and their disease is not progressing. And so we looked at which patients on selpercatinib, which patients had a longer progression-free survival, those that got randomized to selpercatinib or those that got randomized to cabo or vandetanib. And you can see here, I know, I'm sorry, it's a busy slide, but here on the top row here shows the primary endpoint. So the median progression-free survival in the control arm was 16.8 months. And at the time of the initial report in New England Journal of Medicine, the median progression-free survival had not yet been reached. So we knew that it was longer from a statistical point of view than the control arm, but we hadn't even hit the median yet by the time that the study was done. And when we take a look at the overall responses, we saw almost 40% of patients on the control arm had a response, whereas almost 70 patients on the control arm, on the selpercatinib had a response. So this was a very positive study. Also, if you look at the complete responses, almost 12% of patients on selpercatinib had complete responses compared to 4% of patients on the control arm. So this graph here is what's called a Kaplan-Meier survival curve, and this is for progression-free survival. And this is from the New England Journal of Medicine paper. So selpercatinib is orange on the top, and the control arm is red on the bottom. And you can see here that there's a big difference between how long people are living with disease control on the selpercatinib arm compared to the shorter time that people are living dosing on the control arm with disease control. And that when we look at the strength of how different those two lines are, we look at what's called the hazard ratio. And here the hazard ratio is 0.28. That is a highly statistically significant hazard ratio. That means there's really a big difference between progression-free survival with selpercatinib compared to the control. Now, we also really think about quality of life on cancer treatment. We care a lot about people living as long as possible. We care a lot about their disease shrinking up and staying that way for as long as possible, but we also care about how they feel. And so with the RET-specific inhibitors, what we're seeing is that the adverse events related to the drugs are less, and they're less in number, and they're also less in intensity compared to what we see with the multi-kinase inhibitors. And if we look at these columns here with grade 3 or higher, if we look at with selpercatinib compared to the control, you can see that the numbers in terms of the percentages in the parentheses are just smaller than here in the control. So suffice it to say that overall, it really does look like from this phase 3 trial that selpercatinib was the better tolerated drug compared to cabo and vandetanib. So getting back to my patient, he was enrolled in the first part of the first generation selpercatinib trial, Libretto 001, and he started in February of 2019. He thought when he came to clinic a week later that his mass was already smaller. He had diarrhea at baseline because the high calcitonin levels in medullary thyroid cancer cause most people to have diarrhea. His diarrhea went away just after that first week on therapy. He had some mild rash, mild fatigue. He had had a poor appetite when he enrolled on therapy, and he had been losing weight. Those all got better. So he did really well on selpercatinib. And he remained on selpercatinib. However, after he was on it for 36 months or 3 years, he developed growth in just one area of disease in the center of the chest, the mediastinum. And that was referred to as oligoprogression, which means progression in just one place. We did a biopsy to prove it. And then we got permission from the sponsor of the trial to keep him on study, but to allow us to hold selpercatinib while he got radiation to this area that was growing. And then we resumed the selpercatinib on the clinical trial. And today, this patient remains on the trial with all of the other disease remaining in control. He feels great. He works full time. This date of March 23, when he remained on study in the last follow-up, has subsequently been outdated by his last clinic visit, which was just a short while ago. So just briefly, I want to mention this idea of disease progression, because we are seeing with these specific drugs that some patients with thyroid cancer are developing acquired resistance. And one of the important points here is that if that resistance is in only 1 or 2 places and everything else remains in response to the drug, we now know that we can treat those 1 or 2 places with surgery or radiation, and then otherwise keep the patient on the drug that's working really well in order to really get as much bang for the buck out of this effective therapy as possible. So we can talk about how the case might have been handled at different institutions, and maybe you all in the audience can think about questions that you might have for me in the Q&A on germline RET testing, somatic RET testing, the testing methodologies, and then the treatment for a RET mutated medullary thyroid cancer. And then maybe also things that you've encountered in your own life related to barriers to getting molecular testing done in your situation or your friend or family situation. Okay, let me talk briefly about differentiated thyroid cancer. And I see somebody put a question in the Q&A, so that's great. Keep them coming. I'm going to keep on talking, though, just kind of in the interest of time. So for differentiated thyroid cancer, we can see fusions, RET fusions, NTRK fusions, and other fusions. And what we now know is that those fusion-driven thyroid cancers tend to have some particular pathologic characteristics that our pathologists can see when they're looking at it under the microscope. They can describe multinodularity, prominent fibrosis, extensive lymphovascular invasion. These are all things that they can see under the microscope. Those features tend to describe the diffuse sclerosing variant. We also see when thyroid cancers harbor these gene fusions that there's more extrathyroidal extension, more spread to the lymph nodes, and even a higher rate of distant metastatic disease. So at Mass General, our pathologists think that when we see or when they see these features under the microscope, that they as pathologists should go ahead and order fusion tests for those to identify those potentially oncogenic kinase fusions in the tumor. And so our pathologists at Mass General will go ahead and order that testing on their own as part of their complete pathologic workup. That's kind of unusual. Most pathologists, I think, haven't been doing that at their own institutions, but it's tremendously helpful for us at Mass General for them to just go ahead and order that testing so that we find out these results as early as possible. So in terms of challenges that make it difficult to carry out RET fusion testing for all patients with advanced differentiated thyroid cancer, and then how can we overcome these challenges? Let's think about that. And I should say that not everybody with differentiated thyroid cancer needs to have these molecular tests done. But when patients have advanced differentiated thyroid cancer, we're talking about when people have recurrent disease in the neck that can't simply be resected, or metastatic disease that's iodine refractory. Those patients are going to need other therapies at some point in the future, and we think now that those patients should have this kind of testing done. And then what's the best testing? Again, that next generation sequencing really is the best, most comprehensive approach. And so what barriers are out there so that for us to overcome when doing this? So we can talk about doing multi-step testing in advanced thyroid cancer. So you can do testing, which is easily done with a chemical stain in the pathology department for the most common mutation, which is the BRAF V600E mutation. In places where they don't have as much availability in terms of coverage for these tests, doing this multi-step testing can make a lot of sense. In Europe, for example, this testing can make a lot of sense to do because you can do this relatively quick and easy chemical stain for BRAF V600E. If that's positive, you know that that tumor isn't going to have one of these gene fusions, because we don't see both BRAF mutations and gene fusions in the same thyroid cancer. They're mutually exclusive. So you can do this cheap and easy test, and if you have a BRAF V600E mutation identified, you're done. The problem is that, or the reason that we don't do this in the US when we don't have to, is that there are additional things that we can find out from the next generation sequencing panels that are just much more comprehensive. We can identify BRAF V600E mutations, but we can also, when we see BRAF V600E mutations, we can also identify co-mutations that might mean that that cancer is a little bit more aggressive. Or if the cancer doesn't have a BRAF V600E mutation, then it's possible to identify the RET fusions or NTRK fusions or ALK fusions that might be driving that cancer and are druggable with drugs that we have in our arsenal. So if we do all of that testing in one fell swoop with a next generation test, do one test that can give us all of those answers, then really that's a more ideal situation than doing the multi-step testing that takes longer. And sometimes you don't ever get to step 2 when you really needed to get to step 2. So we think in the US that the best approach is to do a comprehensive RNA-based next generation sequencing test for patients with advanced thyroid cancer. And I mention RNA over DNA because when we're looking for fusions, the RNA-based NGS testing is the best test available in our arsenal for identifying the gene fusions. with DNA-based NGS testing, the fusions can be harder to detect. Those tests can still sometimes pick them up, but they don't pick them up as effectively as the RNA-based tests do. So what reasons underlie the initiation of systemic therapy prior to receiving molecular testing results? Again, should we ever start therapy in people with progressive disease without doing this molecular testing? And that's the same question I asked before, with the same answer, is that for almost all patients with advanced thyroid cancer, we have the luxury of being able to do the test and get the results before we have to start systemic therapy, with the one exception sometimes being people with anaplastic thyroid cancer, for the most part. And that's shown here. So sometimes we may need to start systemic therapy right away for anaplastic thyroid cancer, and you can do that BRAF chemical stain. And if it's positive, you know that anaplastic thyroid cancer harbors a BRAF V600E mutation, and you might want to start a BRAF-directed therapy for them right away. But for other patients with other follicular-derived thyroid cancers, we almost always have the luxury of doing the molecular testing before we have to start therapy. So if we identify a RET fusion in a patient who has a differentiated thyroid cancer that's progressive and iodine refractory, we now have two options of treatment for those patients, one being selpercatinib and the other being pralsetinib. And so let me show you those data here. So this slide shows the data from the Libretto 001 trial in RET fusion positive iodine refractory thyroid cancer. So these were patients who enrolled who didn't have medullary thyroid cancer. They had RET fusion positive thyroid cancer, mostly papillary thyroid cancer, but there were a couple of patients with poorly differentiated thyroid cancer, and then two patients in this patient population who had anaplastic thyroid cancer as well, all harboring RET fusions. And what we saw in this older data, there's actually some updated data that just came out in the Journal of Clinical Oncology. But here we see that in the updated analysis, 77% of patients with RET fusion positive differentiated thyroid cancer had responses to selpercatinib. And these responses were very durable. The median progression-free survival had not yet been reached during this analysis. And here in this graph is called a waterfall plot. Basically, each bar represents a single patient. And so the 0 line here is where the patient started at baseline in terms of their tumor measurements. And then after they started selpercatinib, we took a look to see on CT scans how much smaller did their tumors get. And then we measure that in terms of percentages. And in clinical trials, if somebody has a decrease in the tumor measurements by 30% or more, we call that a partial response. So all of these people here, from here over, had a partial response. And then if you have a complete response, you have 100% decrease, the tumors basically go away. And so two of these patients did have complete responses. The side effects with selpercatinib that we saw in the clinical trial were similar to the side effects in the study as a whole that I already talked about. Selpercatinib was very well tolerated overall. The most common selpercatinib related adverse events were dry mouth, some diarrhea, high blood pressure, fatigue, constipation, and nausea. But very few patients had to stop selpercatinib because of the side effects. Now, the ARROW trial investigated pralsetinib in RET-driven cancers, including 21 patients that had RET fusion positive thyroid cancer. And so this slide here shows the data from the ARROW trial in RET fusion positive differentiated thyroid cancer. And the objective response rate was 86%. With a median duration of response of 17.5 months and a median progression-free survival, which you can see here in this graph to the right, of 19.4 months. And so after the ARROW trial was complete, pralsetinib was given accelerated approval for any RET-driven cancer. and then the accelerated approval was withdrawn from medullary thyroid cancer, but it remains in place for any cancer with RET fusion positive disease. So selpercatinib is an on-label option for people with RET fusion positive, iodine refractory, progressive, differentiated thyroid cancer. And this busy slide here shows the side effect profile of pralsetinib. So again, when we think about side effects that really impact the quality of life, those are usually grade 3 or grade 4. See a lot of zeros in that grade 4 column, and very small numbers in the grade 3 column. The most common pralsetinib related adverse events were some inflammation in the liver, mild anemia, high blood pressure, and a mild low white blood cell count. There was one patient who developed inflammation in the lungs, and then there was one death that was attributed to possibly being related to pralsetinib, which was an infectious type of pneumonia. So in oncology, we really want to think about developing an action plan for enhancing RET testing for our patients with thyroid cancer. And in terms of our key takeaways from this program, and we're going to get to the question and answer momentarily, so sharpen your pencils. But basically, we want to make sure that we identify every single patient who has thyroid cancer, who we expect is going to need systemic therapy. And we want to identify every single potential actionable molecular alteration, mutations or gene fusions, so that we can offer precision targeted therapy for each and every patient who has something that's druggable, who needs a systemic treatment. The RET alterations that we're thinking about are mutations in medullary thyroid cancers and fusions in the poorly differentiated and anaplastic thyroid cancers. The treatment guidelines do call for testing for RET alterations, and next generation sequencing is the best methodology for doing this kind of molecular diagnostics in thyroid cancer and other solid tumors as well. And then selpercatinib and pralsetinib are both FDA-approved therapies for the first line when patients have iodine refractory RET fusion positive thyroid cancer. And then selpercatinib is FDA-approved and the first-line therapy for RET mutated progressive medullary thyroid cancer. All right, and with that, I am going to stop. If anybody out there does want CME credit, here's a reminder of that information, and McKenna can share that with you too through the chat. Good. Thanks, everyone.